Dear Chairman, thank you for the invitation to present at the ABC 2021. And the title of my presentation is Left Main Preparation with Intravascular Lithotripsy. Well, as you all know, bifurcation lesion, especially left main, even when moderate or severe calcified, are always very challenging situations. And from the data we have so far, it is well known that even if rotational atherectomy is used, there is no superiority in this patient cohort in comparison to standard procedure. This means that there are obviously some limitation coming along with the biking treatment options such as rotational atherectomy, especially also in left main. So first, there's the inability to navigate towards anatomy and severe angle side branches, as we sometimes see with the circumflex artery, and with rotational atherectomy, multiple wires, while modifying calcium is not possible. And finally, circumferential calcium modification without wire bias is not possible, leaving untreated or unmodified areas behind. The question is now, can we do better? And the intravascular lithotripsy was introduced as a calcium modifying tool, coming with a generator and a balloon catheter. And at the end of the balloon catheter, there are two small emitters, and via these emitters, electric discharge is applied, and this vaporizes the fluid within the balloon, and thereby creating a rapidly expanding bubble that generates the sonic pressure waves. Then they collapse and create a series of microspheres by applying nearly 50 atmospheres, and this makes the vessel more compliant. This is an OCT image after lithotripsy, showing very nicely the microfractures of calcium, and we know from the early study that IVL is most effective in deep calcification, deep calcified plaque structures. The safety and the efficacy of the system has been proved by the CAD I and CAD II studies, and from a very early sub-analysis, we know also that even in the bifurcation subgroup, there is also safety and efficacy when treating with IVL. In a small case series with 23 patients, the colleagues demonstrated very nicely that with IVL treatment in left main, there is a significantly increase of minimal stent area. Accordingly, the diameter stenosis could be reduced significantly. So I think also information from the studies said that from a safety endpoint, the IVL in left main is very safe. So only in 2 patients, hypotension with systolic pressure below 90 millimeter of mercury were documented. And although there was a few use of the possible cycles and impulses with a median of 8 cycles and a median of 80 pulses in total. Whenever required, the energy delivery was distributed in a shorter balloon inflation to avoid profound ischemia. This is now a nice example of a very calcified lesion of the circ and the pathologic distal left main. Please notice that there was already stent implantation of the proximal LAD and circumflex, and here the IVUS shows very nicely that there was a 180 degree of calcium arc in the ostial circ. So this was the reason why there was an inadequate balloon inflation in the very first beginning. So we decided to use an IVL with a shockwave balloon 3.5 over 12 millimeter. We applied 8 cycles with 80 impulses, and finally this resulted in a very adequate expansion of the balloon in this severe calcified situation. This is also shown by the IVUS. Of course, we present it later on. The procedure was then finalized by implanting a drug-eluting stent from ostial left main cross over to the circ with a final kissing and a final balloon, and this is the final angiographic result, which is rather good. Here you can see the IVUS result showing no underexpansion, especially in the ostial circ. I'd like to introduce you to the upcoming BIFU.shock trial, which I think is necessary to demonstrate the efficacy of using IVL even in the left main bifurcation situation. So in this trial, we will include patients with moderate to severe calcified bifurcation lesion in whom 2 stent strategy is decided. We will randomize either to standard balloon angioplasty, plus DS, or lithotripsy, and main branch and side branch plus DS. This is an imaging primary endpoint with the documentation of the MSA, and of course secondary endpoints includes clinical follow-up after 12 months. Finally, I'd like to conclude calcified bifurcation lesions, especially left main, are always challenging. Of course, we have now introduced the intravascular lithotripsy, which might be an alternative to other calcium modification therapies. So I think the most advantage is that we have no wire bias, and we can use it with 2 wire within the vessel, and we have a low risk of slow no flow situations, of course, and of perforations. However, there are concerns about the use of IVL in left main because of the need of prolonged vessel occlusions. However, data we have so far showed that there is no safety issue. However, randomized trials just at BIFU.shock are needed to clarify its superiority upon other debulking devices. Thank you very much for your attention.